Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Rhiannon Ashman, Deputy Editor of MIMS Learning, and I've got my colleagues with me in the studio today.
Hi, I'm Pat Anderson.
And I'm Dawn Liz Powell.
Did you know that hair on the scalp grows at a rate of about 1 centimetre a month, and each individual hair continues to grow for about 6 years? Today we're talking about hair and scalp problems. Hair loss, in particular, can be really distressing for patients, and it's spawned a big industry. Tonics, supplements, and surgical options, including hair transplants, are often very expensive and may not achieve the desired results. So we'll look at what management options are available and how you can best advise patients. First, though, we'll consider what types of hair loss are quote-unquote normal and what symptoms are concerning. We'll look at possible causes of hair loss and consider specific conditions that tend to affect people of colour. Don't forget that you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading.
I think most of us realise that some hair loss is normal. For example, hair loss is a sign of ageing in men. Plus, we use, or should use, hair traps in the shower to stop our drains getting clogged from the hair we lose in the shower. But how much should we expect to lose?
Yeah, of course, some gradual hair loss with age can be normal, as you say. And at any age, a loss of at least 50 to 100 hairs a day is regarded as completely normal. And interesting that you mentioned men, actually, because male pattern hair loss and female pattern hair loss have different features, which we can come back to a bit later.
So that's normal hair loss, but what symptoms would raise concerns?
Well, in a module on MIMS Learning, the red flag symptoms that clinicians should be aware of are listed as sudden hair loss, complete hair loss, there being no apparent external cause for the hair loss, and suspected kerion.
Can you remind me what a kerion is?
Yeah, it's a pus-filled lesion on the scalp, and we'll come back and talk about this as well later because it's a dermatological emergency, so it's an important one not to miss. So coming back to the red flags then, you've also obviously got the universal red flags, things like unexpected weight loss, unexplained tiredness, behaviour change or metabolic changes.
Okay, so sudden hair loss is a red flag. Is it right that sudden hair loss can occur after a shock?
Yes, apparently an emotional or physical shock can cause a sudden loosening of the hair, and this typically becomes apparent several months after the event, usually resulting in handfuls of hair coming out, which can be really upsetting for patients. Hair often recovers again, but not always fully.
But actually, it's much more common for hair loss to be gradual, and this can be caused by, lots of different things. You've got hormonal factors such as childbirth, menopause, thyroid problems. In fact, it's quite well known, isn't it, that your hair often gets thicker while you're pregnant and then it starts falling out after you've had a baby. Conditions like diabetes and autoimmune diseases, for example, hypothyroidism, can cause hair loss. Excessive weight loss or eating disorders can be relevant, and patients might be deficient in iron, protein, zinc or vitamins. And medications are another one, the obvious example being hair loss in people undergoing cancer treatment. And the charity Macmillan Cancer Care has some useful patient information on this, including how to emotionally prepare for hair loss with cancer treatment and options like wigs and hats and hair wraps. Other medication for arthritis, depression, heart problems and hypertension, for example, can also cause hair loss. And an interesting point on medications that I picked up from the red flags module is that as well as prescribed medication, you might consider accidental or deliberate poisoning as a cause of hair loss.
Well, I think Agatha Christie fans will know that thallium poisoning can cause hair loss. It's actually a plot point in her novel, The Pale Horse. And according to that irrefutable source, that is Wikipedia, 2 readers' lives were saved because they recognised the symptoms of thallium poisoning after reading the novel.
I love that.
Amazing.
All the more reason to read Agatha Christie. Another possible cause to consider, a psychological cause this time, is trichotillomania, which is a habitual tugging, pulling or plucking of the hair. And this can be an expression of distress. Sometimes patients don't realise they're doing it, but it often coexists with other mental health conditions such as anxiety. In fact, pulling out eyelashes, eyebrows or hair is specified as a type of self-harm in a module that we've got on self-harm in children and young people. And in terms of what you might see in someone who's doing this, there are usually unequal length, broken hairs and split ends, which doesn't tend to occur with other types of hair loss.
So I think it would be useful at this stage to run through the features of the main types of hair loss.
Yeah, absolutely.
So you mentioned earlier, Dawn, that a lot of people's hair thins or falls out with age, and this is known as androgenetic alopecia. This physiological hair loss may follow the male pattern of a gradually receding hairline and thinning on top of the scalp, or female pattern, which is of general thinning. Typically, there's a strong genetic component to this type of hair loss. There's also alopecia areata, which is localized hair loss, and this is likely to be down to an autoimmune process that can cause scalp itchiness, redness, and tenderness. Local fungal infection can create a similar pattern of symptoms, so that's something to bear in mind. And the type of alopecia areata that causes complete hair loss on the head and face is called alopecia totalis. And the most severe form is alopecia universalis, where patients lose all of the hair on their body as well. Then we've got traction alopecia, which typically occurs as a result of hair styling practices or head coverings that are applied tightly on a repeated basis. Hot oil hair treatments and some colouring or hair dyes may also cause inflammation of the hair follicles, which can lead to scarring and subsequent hair loss.
We do have a module on traction alopecia by Dr. Oluwayemi Bello. This explains that because it's caused by extrinsic factors such as hairstyling, traction alopecia can affect people of all ages, genders and ethnicities. That said, it is most notably been reported in women and girls of Black African ethnicity. In this group, the prevalence rates are as high as 37%.
So what are the main clinical features of traction alopecia?
Well, the hair loss tends to be seen around the perimeters of the scalp, particularly the frontotemporal hairline. Soon after the tight hairstyle has been done, you might see papules, pustules, erythema, tenting and dimpling of the scalp. If the tension is applied over a long period, that's when the patches of hair loss occur. In the early stages, traction alopecia is typically reversible, but it can lead to scarring over time. If scarring does occur, it can cause permanent hair loss. At this stage, the affected areas appear smooth and shiny.
That's an important point, I think, because I mentioned at the beginning of the episode that lots of the over-the-counter treatments for hair loss are expensive and not very effective. But here's a situation where early intervention could prevent further hair loss. Patient education is crucial here, but having said that, the sorts of practices that are usually implicated in traction alopecia, so braids, cornrows, weaves, wigs and locks, and even head coverings, may be of social, cultural or religious importance. So it's not as straightforward as just telling patients not to wear their hair in a certain way.
So what clinicians advise in these situations?
Well, Dr. Bello says that it's essential for patients to understand the causes and potential long-term consequences of traction alopecia to give context for any changes that they're being advised to make. Specifically, you could tell patients that how tightly the styles have been applied and how frequently they're done is important. While the initial amount of tension applied by the stylist is important, it's also things like the addition of hair extensions that can increase the risk of traction alopecia. It's also worth considering how long the hairstyle is worn for, because a longer duration increases the risk.
Dr. Bello also says education of the wider community, including hair care professionals, is important for prevention. I'm white European, so I wouldn't know much about afro-textured hairdressing, but I'd imagine hairdressers who do specialise in afro-textured hair will be aware of the risks of traction alopecia and would be able to advise their clients about how to manage these risks.
So beyond giving advice, are there medical treatments as well?
There are medical options, including topical and intralesional corticosteroids, topical and oral antibiotics, and a topical minoxidil, although high-quality evidence is lacking for these treatments. Camouflage techniques such as scalp micropigmentation or hair paints and powders can be helpful, and surgery might be an option for severe cases.
I saw that this learning module also mentions another type of hair loss called frontal fibrosing alopecia, or FFA, which clinicians need to consider as a differential. And as the name suggests, this is a type of scarring alopecia that commonly affects the frontal hairline. FFA is most common in white women over the age of 50, but there's some evidence that the condition can present at an earlier age in women of African descent. So Dr. Bello says it can be tricky to distinguish between the two conditions, and there's a useful comparison table included in her module, which we link to in the podcast notes.
On the topic of differentials, the most common cause of scarring alopecia in black women, according to another learning module by Dr. Sharon Belmo, is central centrifugal cicatricial alopecia. Similarly to traction alopecia, it was thought that the condition was caused by the use of the hot comb among black women, and later chemical straightening and traction-related hairstyles were implicated. But Dr. Belmo says that a genetic component has now been proposed following reports of CCCA across 2 generations of families in South Africa, including in children with untreated natural hair. And some relevant gene mutations have been identified as well.
Oh, that's interesting. And is that condition treatable?
Again, treatment's challenging, but the module says that early diagnosis is important and general hair care advice, as we've discussed earlier, should be given. The treatment would be aimed at suppressing inflammation and stopping the scarring process to prevent further hair loss, and this might involve a combination of potent topical and intralesional steroids.
Based on our discussion so far, I think the type of alopecia is identified through reviewing the signs and symptoms, but are there any investigations that could be performed?
Well, the red flags module says you could consider baseline investigations such as FBC, UNEs, liver function tests, thyroid tests, ferritin, HbA1c and inflammatory markers. But as you say, I think diagnosis is largely based on careful history and examination.
Yeah, so in terms of the history, thinking back to those red flags that we outlined at the start, you'd want to determine how quickly the hair loss had happened, the quantity and distribution of hair loss, and you'd be looking for any possible external cause, so asking about medication changes and stress, that sort of thing.
That reminds me, Rhiannon, you mentioned kerion as a red flag at the start. To expand on what you said, it is a painful, boggy, pus-filled swelling over the scalp as a complication of severe tinea capitis. Patients may also have a fever and swollen glands. It is considered a dermatological emergency because without prompt systemic steroids, destruction of the hair follicles and permanent hair loss can occur.
So as a reminder then, tinea capitis is of course otherwise known as ringworm. It's a fungal infection that's most commonly seen in children, but it can also occur in adults. And as you said earlier, Pat, this local fungal infection can be misdiagnosed as alopecia areata because of the patches of hair loss that occur when hairs over the affected area become brittle and break. And the British Association of Dermatologists patient information leaflet on this says that symptoms of tinea capitis include itching, redness and dryness of the scalp. It needs treatment to prevent it from developing into a kerion.
So going back to hair loss conditions in general, in non-emergency situations, given that treatment options are limited, is referral usually warranted or not?
Well, the red flag module says that referral, depending on local pathways for a second opinion, may be useful to confirm the diagnosis and to further inform cosmetic management options. And alopecia areata requires referral if more than 50% of the scalp is affected.
And actually, while you're right, Pat, that treatment options are somewhat limited, our colleagues on MIMS reported earlier this year that NICE is now recommending ritlecitinib for the treatment of severe alopecia areata. And this is the first time a medicine for this condition has been recommended by NICE for use in the NHS. Ritlecitinib is an enzyme inhibitor and it reduces inflammation at the hair follicle. The MHRA authorisation was based on the results from a pivotal study in alopecia areata patients with 50% or more scalp hair loss. The trial showed that ritlecitinib 50 milligrams daily was more effective than placebo at improving hair regrowth.
So that's interesting that new treatments are in the offing and patients may be reassured there could be more options in the future.
Hi, I'm Chloe Harmon and I'm the editor of MIMS, which provides prescribing information and tools that complement the brilliant educational modules on MIMS Learning. You might already know that MIMS provides a database of concise summaries of prescribing information for more than 3,000 medicines. We also offer a range of other resources to support your prescribing, such as our drug comparison tables covering topics like HRT products and switching antidepressants, our product trackers, including our highly popular drug shortages tracker, and visual guides to diabetes and respiratory devices, which are especially useful for healthcare professionals running clinics for these conditions. Of course, we also bring you all the important news and updates affecting your prescribing practice, which you can receive straight to your inbox in our email bulletins. As a healthcare professional, you're entitled to limited free access to MIMS online simply by registering. And of course, if you or your organisation subscribe, you receive full, unlimited access to the whole range of MIMS resources. To find out more about MIMS, visit mims.co.uk.
So what have we learnt today? Here's a quick recap of some of the take-home points from our discussion. While gradual hair loss is more common than sudden hair loss, the latter can occur after an emotional or physical shock. This typically happens several months after the event and usually results in handfuls of hair coming out, which can be really upsetting for patients. The hair often recovers again, but not always fully. We considered a number of potential causes for hair loss, including medications, diabetes, eating disorders, childbirth and thyroid problems, as well as trichotillomania, which is habitual pulling or plucking of the hair, and this can be a form of self-harm. The prevalence of traction alopecia is as high as 37% in women and girls of Black African ethnicity. In the early stages, it's typically reversible, but over time the hair loss becomes permanent. There are some medical management options, but patient education is the mainstay here. Alopecia areata is localised hair loss and is likely to be an autoimmune issue. It can present similarly to fungal infection because of the patchy hair loss, itching and redness. If there is fungal infection, be on the lookout for a kerion. This complication of tinea capitis needs prompt treatment with systemic steroids. And finally, I learned that NICE is now recommending ritlecitinib for the treatment of severe alopecia areata, and that this is the first time a medicine for this condition has been recommended for use in the NHS by NICE. Thank you for listening. We've been the MIMS Learning editorial team, and this episode was produced by Till Owen. Next week, Sangeeta Krishnan will be talking to neurogastroenterology trainee Dr. Mohsin Butt on disorders of gut-brain interactions, or what you may have previously called functional gastrointestinal disorders. We're looking forward to seeing you then. Goodbye for now.